All right, why don't we go ahead and get started? Good morning, everyone, and welcome to another Tuesday morning virtual cardiovascular medicine grand rounds. Thank you all for joining us today. As always, few housekeeping issues, and you should all know by now regarding questions, hand raise function, or type the questions in the chat function. Next week, we have one of our own, Dr. Jennifer Huang, making a presentation, so please join us then. But today, it is my pleasure to introduce our grand round speaker today, Dr. Jean Bukhman. And this is one of mine because Jean is my guest today. Dr. Bukhman is a cardiologist and medical anthropologist. He heads the program in global non-communicable diseases and social change at Harvard Medical School. He's also the Senior Health and Policy Advisor on non-communicable diseases at Partners in Health, where he also directs the NCD Synergies project. In addition, he's an attending cardiologist at the Brigham and Women's Hospital. Jean, between 2015 and 2020, was the co-chair of the Lancet Commission on reframing NCDs and injuries for the poorest billion, and is now the co-chair of the 23-country NCDI Poverty Network. And if you haven't read that report from the Lancet Commission, I think that's a really important one to read. So Dr. Bukhman completed his training in medicine and doctorate in medical anthropology at the University of Arizona. He completed his internal medicine residency at the Brigham and Women's Hospital and cardiology fellowship at the Beth Israel Deaconess. And really for all of his career, and I've known Jean for quite a while now, he really has been focused on non-communicable diseases and injury, especially in those who are living in extreme poverty. And I think that's part of what we will hear from him today. Jean has done a number of jobs recently, or between 2010 and 2015, was in Rwanda as a senior technical advisor to the Ministry of Health. And I know from my previous life at WHO, we interacted quite a bit with Jean serving as an advisor on multiple committees, including the WHO's Global Coordinating Mechanism on NCDs. In addition to all of that, Jean is a great colleague and a good friend, and it's an absolute pleasure, Jean, to have you here today. Thank you.
Wow, Yuri. Well, thank you. It's such a pleasure and an honor to be able to speak to the cardiovascular medicine division at Yale, and you're very fortunate to have one of the leaders in global cardiovascular health with Oyeri in your division, and it was a pleasure having a chance to work with you when you were at WHO, and thank you so much for inviting me. I've titled this talk the cardiovascular disease of the poorest billion, towards a science of integration, and I'll maybe start with where I started, which was as a medical student, graduate student, medical anthropology, working on another chronic disease, which in the former Soviet Union, the doctors there, they call these patients chroniki, because they were not responding to standard treatments and had developed really a very persistent disease, and this was drug-resistant tuberculosis. And at the time, the impulse, I'd say, of the international health community that the former Soviet Union was suddenly subjected to its mercy, really, in the 90s, after having been strong, independent, economically solid entity at least in the 70s and early 80s. That the impulse is really to say that this disease was too complicated to treat, that it wasn't really a priority because there were forms of tuberculosis that were less expensive to treat, and that maybe at the time the thought was that they were less infectious. And so really the only option was to allow these patients to die. And the impulse of the former Soviet doctors at the time was that in a way that this was very clearly some kind of racism, really, in effect, that the former Soviet Union was now being subjected to effectively a kind of racist world system that didn't value their lives as much as the lives of people in New York or in Colorado that at the same time were being treated for the same disease quite effectively. And I think that this moment really uncovered the kind of double standards that we've had in global health for so long, and that we're also, I think, seeing in COVID revealing in the way that we're finding now it unacceptable that parts of the world would wait so long to be vaccinated. But at this point in time, I would say that these differences were even more stark, and I think that they've been particularly stark for what we might call some of these chronic diseases that I think push the bounds of global solidarity, where we have a world system that is designed maybe to respond to infections that are very clearly of danger to high-income countries, say cholera epidemics, but is not really based on a principle of global solidarity that would include people with treatable chronic diseases. And so encountering this issue and the response of the Soviet physicians, and I felt this quite personally at the time, because my family had come recently from, I was born in Ukraine and had come over fairly recently from the Soviet Union, saw what was really at stake, and it made me want to explore more deeply if there were other ideologies at play, as a medical anthropologist, if there were other phenomena like this in global health. And I was particularly drawn to the issue of cardiovascular disease. Now, at the time, and I went from this project to the Brigham in 2001. This was really the beginning of the birth of global health, and there are a lot of compounding issues here, but you could argue that the fall of the Soviet Union is one of the things that's precipitating this, as we've talked about. But really, just even from a bibliometric standpoint, if you look at the term global health, it doesn't really exist to any significant degree in the literature before around this time when I was starting residency at Brigham and Women's. And this was a time when a lot of global institutions were being created. Bill Fahey, who had been one of the champions of the smallpox eradication, was brought into the Bill and Melinda Gates Foundation, which was just formed around that time to advise on it. There was the creation of the Global Fund, massive commitments from the President's Emergency Initiative to address HIV/AIDS. That really marked in this period a massive growth in financing for global health. And you can see the total development assistance for health really climbed almost 2 or 3-fold here between 2001 and 2011, largely driven by the response to HIV. Now, in a place like Russia, there was a sense that if you wanted to kind of have a simple narrative with single diseases that were really important, and in global health, HIV had become a singular disease in that way in terms of the response. If you looked at the rank order of disability adjusted life years, or as a measure of disease burden, ischemic heart disease and cerebrovascular disease are very high. And so it seemed puzzling why there wasn't much of a global response to that, as opposed to at least some cooperation around something like tuberculosis, which you can see is much further down there. And there was commentary at the time. Take, for example, Steve Leader at the Earth Institute at that time, writing that the great contemporary communicable diseases HIV, but also tuberculosis and malaria, and the health problems of women and children have captured virtually all the attention and money devoted to international health problems in this publication, A Race Against Time. And within the US public health context and high-income public health context, there was already this sense of cardiology, cardiovascular disease as being the most important thing, at least in those contexts. And this was driven by the mid-century epidemics of coronary heart disease in those countries, and maybe more importantly, the very effective response and subsequent decline through changes in behavior, smoking, but also therapies for many of the risk factors. And this went along with earlier notions in the 1970s that were looking at things like epidemiologic transitions. This is Abel Omran's classic graph from the Millbank Quarterly from 1971, showing historically in England and Wales the relative growth of heart disease as a major cause of death relative to infectious causes, and sort of a sense that developing countries were going to be going the same way, and so there was an importance of focusing on this and preventing it, and of course this had the background for this had been established by the Framingham Heart Study that had identified the classic cardiovascular risk factors, but also Ansel Keys' 7-country study that had shown major differences in coronary heart disease across a number of countries that were associated with differences in diet. And then the way that these findings, particularly about behavioral risk factors, were translated in Finland under Pekka Puska and others in the North Karelia project in a way that really became a model for controlling cardiovascular disease by attacking these risk factors at a community level, also treating the risk factors pharmacologically. And this really became the model for cardiovascular disease control in Europe through the World Health Organization's European Country Office in Copenhagen. And this was subsequently, as we'll see, generalized to all to all chronic diseases, and subsequently was called all non-communicable diseases that shared these same risk factors as a public health strategy. And increasingly, cardiovascular disease began to become the kind of metonym or the part that stands for the whole for non-communicable disease, and a particular kind of cardiovascular disease, this sort of coronary heart disease and stroke. And these claims are made on the basis of the distribution of non-communicable disease deaths that were due to cardiovascular disease conceived in this way, and also delving further that even the diseases that the non-communicable diseases that were not cardiovascular had these same shared cardiovascular risk factors. And so in the kind of early mid 2000s, at the same time that there was this rise in global health activity for the poorest countries that was focused largely on, as Stephen Leder said, on tuberculosis, HIV, malaria, and maternal and child health, there was a parallel movement that had been building since the 1980s in the European Country Office of the World Health Organization, and that then had been transferred to headquarters that was based very much on this kind of cardiovascular paradigm. And you saw along with that these predictions of cardiovascular pandemics or epidemics, and you can track that that term as well in PubMed. This also exploding in the 2000s as a way to kind of promote the notion that cardiovascular disease was important. Now within WHO headquarters, although there had been a broader disease-specific notion of non-communicable disease that went back to the early 1950s, shortly after the founding of the World Health Organization, by the 1970s, 1980s, taking this European Country Office kind of model, there had been a change to a more integrated vision of NCDs that was really based on this notion of common risk factors, tobacco, physical inactivity, unhealthy diets, unhealthy use of alcohol, which came somewhat later, which had the effect of excluding, in effect, a lot of the non-communicable disease burden, as we'll see, and really became crystallized by about 2008 as this 4x4 model, four diseases, four risk factors, four shared risk factors that were largely cardiometabolic, essentially. Now, around this time, I had finished my residency. I was in fellowship, and this was actually around the time that the first point of care ultrasound equipment really became widely available through Sonosite, in particular. Folks were working with things like the Titan and the Micromax at that time. And I had the opportunity to start working with Partners in Health in Haiti and Rwanda, where they were working with governments in the middle of this kind of HIV response to rebuild health systems that had been neglected in many cases, in the case of Rwanda, because of it actually being destroyed in the genocide, but really kind of chronic underinvestment and on the tails of things like structural adjustment programs, countries actually being discouraged by international institutions from investing in health in the 1980s and 1990s, bizarrely. But scenes like this, hospitals really in horrible disrepair. And having been in this atmosphere of why cardiovascular disease was important, on the one hand, going out to a place like rural Rwanda, this kind of eastern corner of it, you might think that either there wasn't a lot of cardiovascular disease there, period, or what you would be looking for would be, at that time, heart attacks, hypertension, things like that. And as we work to rehabilitate this hospital, along with the government and supporting its overall strategy, we started to see that in these wards that were rebuilt, there actually was a lot of cardiovascular disease, and there was a lot of non-communicable disease more broadly, as we'll see. And it actually occupied, particularly heart failure, a significant portion, say in 2006, of the hospital time. And that actually, as the hospital was rehabilitated, it became a larger fraction of that time, because there was an overhang of people with these really severe conditions that had not been treated. And what was really incredible was the opportunity then to, with early Sonosite equipment, to be able to do ultrasound on them in this very remote place, and to look at what exactly the etiology of this disease was. And this was a very young population. The median age was about 36. And so the initial cohort, this is a very early series, small number of patients, showed basically what I learned later had been shown all over Africa in the 60s and 70s and 80s. In fact, prior to this period of healthcare disinvestment during structural adjustment, that there was a lot of rheumatic heart disease, a lot of congenital heart disease, a lot of cardiomyopathies, some relatively rare conditions like endomyocardial fibrosis that we ended up writing about a bit. But very little of what was suspected to be coronary disease on the basis of risk factors, age, and regional wall motion abnormalities. And what was fascinating for me later to learn, and we wrote about this, was in doing interviews more extensively around the world and looking at the historical literature. There were a lot of historical antecedents that had shown that this was sort of the pattern of cardiovascular disease in the region. And one thing that was really interesting to see was this work by Paul Dudley White, who, as many of you know, was sort of the preeminent cardiologist in the world in the mid-century, from Mass General Hospital, visiting here Albert Schweitzer towards the end of his career in Alsace, but actually having a team in 1960 from Massachusetts visit the clinic, the Schweitzer Hospital in Gabon. And at that time, we were in Rwanda with portable echocardiography machines, but at that time they were there with portable EKG machines. And they came to sort of similar conclusions. And he wrote that the high prevalence of mitral stenosis is astonishing. We believe strongly that it's a duty to help bring to these sufferers the benefits of penicillin prophylaxis and of cardiac surgery when indicated. The same responsibility exists for those with correctable congenital defects. And then there were questions about, should this be done? Should the cardiac surgery be done at the local hospital, or should patients be transferred out? Which is very much the same situation that we, that we still face around the world, and that the one cardiologist at that time in Rwanda, Joseph Michimbitsi, pediatric cardiologist, and I were also struggling with that same question about what do we do with these patients that need cardiac surgery. So in effect, what we discovered was that this narrative that globally was selling cardiovascular disease as the most important thing because of this kind of coming pandemic of risk factor driven cardiovascular disease, while important, actually was leaving on the table and not really bringing to light the endemic burden of pre-transitional cardiovascular disease that in his own work, Omron in England, you can see that cardiovascular disease was always there. It's just that its pattern may have been different, as we'll see. And also, it was not the most important thing. It wasn't, singularly, a disease that you could target. And that's always been a challenge for public health in dealing like things with, drug-resistant tuberculosis or less common diseases. We wanted to have, one or two big diseases that we focus on. Another thing historically that we discovered is that, in fact, in the United States, in the early years of when cardiovascular disease overtook disease of the heart, in 1910 actually overtook tuberculosis and pneumonia as the major cause of death, that we think that this was actually rheumatic heart disease significantly as much as it was ischemic heart disease. And as you can see in the American Heart Association's own bulletin in 1927, they were really drawing on these comparisons between heart disease and tuberculosis, which I had worked on previously, as I mentioned, but not in the way that we might imagine. What they were imagining as cardiovascular disease was really in terms of these things like rheumatic and syphilitic heart disease, congenital heart disease, and the very clear link with poverty, probably influenced by socioeconomic conditions, and the same kind of urgency and public health importance that people understood in terms of tuberculosis at that time. So in this stage in our work, there was really a practical question about, we've identified this set of patients that are there at these hospitals in rural Rwanda, and what do we do about it? And one of the first insights that seemed evident was that given that there was this pattern of types of cardiovascular disease, that we could maybe make some key observations about what was important. So the first thing was, in general, if the health system that was largely driven by nurses, generalist physicians at the time, were to take care of these patients, the first thing that was important was to identify patients that were unlikely to have heart problems. They're unlikely to have heart failure, because there's certainly a lot of patients that were referred for suspicion of heart failure that didn't have it. It was really crucial to identify potential surgical candidates, and it was clear, for example, that if you have severely depressed LV function, that you're not really a surgical candidate, and that there are other kinds of patients that maybe needed to be prioritized. And that there was a need for cardiology referral, and that there was a need to identify patients with unique management pathways. So, for example, cardiomyopathies that would be treated in a distinct way, as opposed to a variety of valvular diseases that didn't really benefit from goal-directed therapy, or didn't necessarily have any evidence-based distinctive medical management pathway in terms of whether whether you're talking about severe AR, severe AR, TR, MR, and mitral stenosis, which of course has a distinct medical management pathway in the short term while patients are awaiting full cardiology evaluation. The other observation was that a third of these patients had cardiomyopathies, which was easy to identify in a single parasternal long axis. Again, that they're not cardiac surgical candidates, and there's probably no need for cardiology evaluation if this could be ascertained reliably. And that there were only a couple findings that otherwise had major management implications at this level of the health system in terms of mitral stenosis or dramatic pericardial effusion. And we, on that basis, created this kind of schema of 5 clinical pathways at this setting that were important, that had diagnostic criteria that are based on a combination of hearing or not hearing a murmur, and then a very small number of echocardiographic findings. Essentially, did they have severely depressed LV function? Yes or no. Did they have mitral stenosis? Yes or no. Did they have a huge RV? Yes or no. Did they have a big pericardial effusion? Yes or no. And then if their IVC was really dilated or not. And so I think this is really, as far as I'm aware of, the first published work on point of care, simplified point of care echocardiography in this kind of setting that was performed in the late mid 2000s, and we developed management protocols based on this. Now, the other thing I was talking about that's a challenge is that this was not the most important thing. I mean, there were certainly really dramatic presentations, patients that could benefit from cardiac surgery, patients that could benefit from medical management, and there was a lot to do, but it wasn't the kind of thing that you're going to have a full-time job in doing at a district hospital. You aren't going to be a cardiologist or a heart failure specialist as a mid-level provider working at a rural district hospital and be busy enough to just do that. So that's one issue. From a public health standpoint, there's also this issue, and you can sort of see that these diseases, as opposed to this kind of global narrative of, look, this is largely preventable through known risk factors from Framingham, that this just isn't true for the kinds of diseases that we are seeing, that these are not largely preventable. And later we did work on quantifying this, and you can sort of see the difference between an environment like high income country, where most of the cardiovascular disease burden is accounted for by the kind of classic behavioral and metabolic risk factors, whereas in a country like Niger, that very relatively little of it is, and particularly if you look at younger ages, where often we give priority in public health, that this is similarly less the case. And so this is a challenge for a view of public health that's based on focusing on a small number of diseases, a small number of risk factors. And it really made me as a cardiologist stretch myself into areas that I wouldn't normally be focusing on, and really have to think about integration in a way that I hadn't in practice in Boston. And if you looked at this on from a public health standpoint in Rwanda at that point, part of what was going on was that if you looked at, we looked at the rank order of disease burden in Russia in terms of ischemic heart disease being the most important thing. In Rwanda at that time, the counterpart would be things like pneumonia, lower respiratory infections on the left, HIV, diarrhea, maternal conditions, tuberculosis, all the things that had been focused on in that kind of golden age of global health in the first decade of the 2000s. And even in that case, there was some work on integration in terms of grouping some of those diseases together through things like community-based integrated management of childhood illness. In some cases, there were relatively more vertical disease-focused public health strategies like universal access for HIV. But what really characterized the non-communicable diseases and injuries was that they were part of this long tail of the disease distribution. And even if you focused on things that we care a lot about and that maybe have a global profile, like cervical cancer, you see there, rheumatic heart disease, they just were not comparable in terms of magnitude of public health importance as something like tuberculosis. And so there's even more of a need to be thinking about integration in that sense. How do we make this from a management standpoint, from a very health system that has very limited management capacity to organize initiatives? How do we make this manageable? And part of the answer was that we were, along with these cardiovascular diseases, if you looked at the face of other patients that were had what we would call non-communicable diseases, there was a very similar story. So if you look at a group of patients that we saw around the same time, so young man in the right-hand corner with insulin-dependent diabetes, a child, say, with Burkitt's lymphoma, in the middle there, the woman in the left-hand corner that's standing next to the community health worker with the bag to the right of her with the child. She had rheumatic mitral stenosis that was treated with cardiac surgery and did well. Patient with peripartum cardiomyopathy standing next to the gentleman with the bicycle. In the left-hand corner, a child who had burns from falling into a fire with uncontrolled epilepsy, a child with a cardiomyopathy in the middle that recovered, presumably was maybe myocarditis, and then a young woman with asthma who was also being exposed to household air pollution from cooking stoves. That there was a similar story where these were not kind of diseases that were going to be addressed and prevented through the strategy that was being put forward globally in terms of focusing on these preventable risk factors, but at the same time, no one of them would really benefit from a particularly vertical approach. And so there was a large argument for integration here. And we started thinking about these kinds of principles of planning for the long tail that need to leverage existing inefficiencies in the health system, that we needed to progressively decentralize services, and that there was a kind of optimizing of how services were grouped together for quality. And there's also sort of a principle that in terms of where to begin, that this notion of addressing patients with the most severe disease first had a lot of benefits, both from the standpoint of equity, but also from the standpoint of health system development over time. And so you could see in Rwanda, if you look at a typology, say, of just one area of non-communicable disease services, say, tuberculosis, HIV, neuropsychiatric conditions, other NCDs, palliative care and rehabilitation. What we saw is that in Rwanda, shortly after the genocide, there was a real destruction of health infrastructure in 1994. And really, patients were being taken care of at major teaching hospitals from all over the country, and they were mainly being treated for mental health issues, and also actually NCDs. There wasn't a lot of HIV treatment going on there. By 2000, you started to see decentralization of mental health and epilepsy treatment down to the level of district hospitals through the training of nurses that were specialized in that. And that was a certain kind of decision, right? It was a certain kind of integration that there could have been other diseases that were grouped together. For us, it might be strange that epilepsy and mental health is grouped as one function, but this had historically been the case in a lot of African health systems. By 2005, there had been decentralization of HIV and tuberculosis services at the district hospitals, but they weren't available at lower levels of the health system. So what we saw was that there was a real opportunity to decentralize treatment for non-communicable diseases, chronic non-communicable diseases, down initially to the level of district hospitals, and that this would really involve chronic care of patients with these kinds of severe conditions, and that we would have to, as a package, train mid-level providers to be able to manage those in the same way that had been done for mental health and neuropsychiatric conditions. So by that time, over the next 5 to 10 years, tuberculosis and HIV were decentralized to health centers, and NCD, this sort of NCD model, and we'll talk a little bit about what that evolved into. These initial district hospitals that we started working at became a base for training the rest of the 40 or so hospitals, outpatient facilities in the country, to be able to deliver the same care. And then using that as a foundation, those nurses then trained staff at lower levels of the health system to deliver care for more common conditions like hypertension, type 2 diabetes, asthma, as part of an integrated chronic care strategy that also included standardized therapies for tuberculosis, HIV, and mental and neurological disorders. And there's a real logic to kind of starting, as opposed to immediately starting at the primary care level in these really underdeveloped health systems, working initially at the district hospital level, where patients had a very high risk of mortality in the next 5 years if they weren't put on treatment, that there was the advantage of building leadership for training, supervision, and mentorship, and that this goal of getting these services out at 100% coverage could be done very quickly in a matter of 5 years or so, and it would build confidence and experience in including these services in the health system. And that's exactly what happened in Rwanda. Eventually, what this became is what we now call the package of essential NCD interventions plus, building on WHO's package of essential NCD services for primary health centers. This was focused on intermediate facilities, and is being now promoted by the World Health Organization in the African region. And as an example, can include things like level 1 echocardiography, as we've talked about, management of heart failure, post-cardiac surgery, anticoagulation, hypertension, renal failure, training of nurses at lower levels of the health system, but also medical management of other similar diseases that require careful care, that where you're dealing with medications that have narrow therapeutic windows, that are not the same as the kind of highly standardized treatments that you might provide at health centers. And I flag here that eventually, if echocardiographic screening of something like rheumatic heart disease there was evidence that had clinical benefit, these nurses could provide that kind of service, but not at this point. And this approach was outlined in a book that we published from this initial experience in 2011. And since that time, we published long 10-year outcomes for cardiovascular patients, where the outcomes are similar to what we found in cardiovascular registries from urban centers and things like Thesis HF from Africa. And we documented a very high level of agreement between the nurse and the cardiologist. And this has been published initially in JACC heart failure in the early 2000s, and then more recently in circulation and JACC itself, in terms of the 10-year outcomes, as well as sort of documenting this epidemiology. And also, we've documented very nice outcomes for patients with who actually ultimately underwent cardiac surgery for rheumatic heart disease in particular, and were anticoagulated in rural facilities, where we really have had, at least in this initial follow-up at 10 years, had no deaths that were related to anticoagulation issues. Now, in terms of what the implications of these initial observations were globally, we found that we had to turn to that because we suspected that this was not these are not issues that were restricted to Rwanda. This was probably a more general issue for populations living in extreme poverty. And I was mentioning in response to what was happening with global health in the early 2000s, this kind of cardiovascular risk factor based model of NCDs was being promoted as the future of the global health response to NCDs. And this was the kind of picture of NCDs that was put forward in journals like Nature. There was a very kind of middle income focused portrait of NCDs that was based on this sort of risk factor approach, aging, urbanization, typical risk factors, which are all really important issues. But we're interestingly kind of creating this blind spot around the rural poor in the same populations that we're tackling tuberculosis, HIV, malaria, et cetera. And so we began in Rwanda by having the first meeting, policy meeting, that called out this sort of these endemic conditions, rather the epidemic of cardiovascular disease that had previously been talked about globally. And we elevated this in a conference that we held at Harvard in 2011 that was saying that we really needed a distinctive focus on this, because we were seeing that what was happening in terms of global policy was creating a blind spot. And in fact, when the world convened in 2011 to have its first high-level meeting on non-communicable disease, exactly what we were afraid of happened, which was that these diseases were presented as mostly lifestyle and diet-related illnesses that have become the major killers across the world. And if you look at the investment case that was made globally at that point in 2011 by WHO, it was almost entirely focused on essentially statins and blood pressure drugs for people at high risk of classic cardiovascular disease. And you can see this in terms of the lines in kind of mauve there, or the bars in mauve, and the salmon colored, which is screening for cardiovascular disease, and then multi-drug therapy. And this is almost the entirety of the investment case for all non-communicable diseases. And as you'll see, like you can imagine, non-communicable diseases includes most of the ICD codes, and so it's leaving a lot of stuff on the table here. And the monitoring frameworks that went along with that were communicated to governments were again very much focused on this kind of Framingham, Finland, North Korea model, which is important, but again creates blind spots. And the basic problem was that, in the same way that in the former Soviet Union, where I'd started working, there was kind of an African approach to Russia, where a model of treating tuberculosis that was working in Africa was applied in Russia with bad results. There was a similar kind of Russian approach to managing non-communicable disease in Africa that was also not responding to feedback from African leaders that were saying that this was inadequate. And so in 2013, we launched the NCD Synergies Network in Rwanda, brought leaders from around particularly Southern and Eastern Africa to begin South-South collaboration for integrated health systems that would address a much broader range of non-communicable diseases and injuries, particularly among those under the age of 40. And at the time, the Minister of Health of Rwanda called for this target of massive reductions in non-communicable disease and injury deaths by 2020, particularly in those under 40. And this was in opposition, not in opposition, but in complement, I guess, to the global targets that were focused on reductions in deaths in those between the ages of 30 and 70, and more modest reductions. And out of this work, and the opportunity that we had to participate in the financing working group of the Global Coordinating Mechanism in 2015. Some of the participants in this network, you can see folks from Malawi, Rwanda, Tanzania, other countries that were involved in this network, presenting at WHO, saying that our burden of disease and the response that's necessary is different. And this got the attention of Lancet, that became convinced that what was needed was really a dedicated commission that was focused on this issue. Now, the Lancet had in fact actually been quite instrumental in constructing non-communicable disease as this kind of lifestyle issue, and in fact, its commissions historically, when I started looking at them, were kind of amusing in a sense, in that they were things like this commission to investigate the manufacture and characteristics of beer in Munich, or a special commission on Sicily as a health resort. And when the Lancet had been publishing in the run-up to the high-level meeting in 2011, its own series on chronic disease and non-communicable disease, this was the face of this that it was putting forward. Again, a very in this case, it seems like high-income country, at least, face of this being applied to and really stigmatizing, I would say, low-income countries. And so in response to this, the Lancet, I'm very happy that this commission that we formed in 2015, which ended up being a massive effort over a period of about 5 years. When it was published this last year, the Lancet wrote that the evidence and recommendations of the report prompts the expansion of the NCD agenda as a matter of equity and justice for the world's poorest. And this is in the journal that had effectively constructed significantly over the prior decade and NCDs as they were. And this commission involved a group of 23 blue ribbon experts. In some ways, I'd say most importantly, Bongani Mayosi, who is a mentor of both mine and Oyeri's, and who was really a towering figure in global health and in African cardiology, the dean of the University of Cape Town at the time, who had been very vocal about bringing to the fore the cardiovascular diseases of extreme poverty and renewing interest in making substantial progress on issues like rheumatic heart disease, was really the inspiration for this in a lot of ways for myself and my co-chair Anna Makumbi from the Ministry of Health in Mozambique, but also generalizing that to the non-communicable disease response more widely and building a global movement to address it from the bottom up. And the commission focused on systematically sort of taking these intuitions that we'd developed working in Rwanda and Mozambique and in South Africa, other places, and seeing if we could quantify this, what we're talking about in terms of the nature of the burden, what the kind of interventions are, what the financing issues would be, and to really build a global movement to address this. And there was this is a very productive commission. There were something like, maybe I'll show something on the order of 20 outputs in addition to the main commission report, including things like this modeling study, which looked at the magnitude of the attributable risk from infectious causes and how it compared to things like tobacco, et cetera, in Africa. And you can see that in sub-Saharan Africa, there's something like 3.8% attributable risk for NCDs due to tobacco, as opposed to 11.7% for infectious risk, but really most of the risk being not explained by any modifiable risk factors that we were able to model and sort of consistent with what our hypothesis was. But the most impactful thing I think that the commission did, which has never really been done in Lancet commissions before, was that we simultaneously supported 16 national NCDI poverty commissions in low and lower middle income countries to conduct the same analyses at a local level. And they have also published their reports, and in some cases are now publishing them in peer-reviewed journals. We were able to show where the poorest people in the world live, which is largely in sub-Saharan Africa and rural South Asia, that they're largely under the age of 40, subsistence farmers still, and that we were able to quantify what the magnitude of the gap, this NCD and injury among the poorest billion, how it compared to other conditions that were targeted for the poor in the early 2000s. You can see that it's a surprisingly comparable kind of magnitude in terms of what's in the dotted line there. And then how much overlap there was with this 4x4 agenda that was coming from the World Health Organization. And you can see that a lot of the 4x4 agenda was not focused on the world's poorest billion, which is outside of the dotted line there, and that there was some overlap, but not dramatic overlap with what the real burden of NCDs and injuries was in the world's poorest billion. And in particular, as we saw later, this was even more the case in the populations that were under 40. Since then, there's been some expansion of this agenda to include mental health and neurologic conditions. There might be some consideration of road traffic injuries. But even then, this agenda really is incomplete, and there's this substantial, what we call NCDI poverty gap. We also showed that this burden was very avoidable, and that it was very diverse, particularly in younger populations. that there was a very large number of interventions to address it that it wasn't just like, a handful of best buys that were focused on risk factors, but it included everything from surgery, rehabilitation, medical management at all kinds of levels of the health system. And that many of these interventions were as cost effective and as equitable as the ones that have been prioritized for maternal and child health. Then in contrast to the global best buys that were largely focused on prevention and promotion, that when countries did deliberative priority setting exercises, they ended up prioritizing a lot of interventions at referral hospitals, at district hospitals, at health centers, as well as in the community. And so what our major call has been is that there's a real need for a science of integration in global health delivery that gets us past this paradigm of focusing on a handful of diseases on the one hand, or the entire health system on the other hand. How do we actually implement priority interventions when there are so many of them, and what is the science to doing that? And one way that we started to unpack this in the commission was by grouping interventions around integrated care teams at different levels of the health system, and again with these notions of progressive decentralization and the way that these teams relate to one another. And in particular, you can see Penn Plus being there as one example of something that can be scaled rapidly, although there are many others. And here, kind of a visual representation of how that relates to other services, but also potentially how you can leverage advocacy movements around some really high priority, high equity conditions like type 1 diabetes, but linking them to these notions of integrated care teams so that they're lifting a group of patients that have conditions with related needs and similar kind of issue characteristics. We also showed that the poorest countries really do not have the money to deal with this on their own, that even if you project very optimistically out to 2030, high rates of economic growth, high rates of investment in healthcare, that poor countries particularly low-income countries, do not have the domestic resources to deal with this, and they have absurdly low levels of health spending, in part because of this, this history of colonization, continued exploitation in the world economic system. But it's crazy that they're currently spending on the order of $30 per capita, $20 per capita, when we're spending $10,000 per capita here. It's really kind of obscene. But the notion of these countries with per capita incomes of $300 or $400 have the resources to be able to deliver adequate care is just not realistic. And we also really showed that most of this was because of their inability to finance care for non-communicable disease and injuries. We also showed that the current approach to NCDs globally has been incredibly ineffective in raising and increasing development assistance for health that really increased with the HIV movement, but is really flatlined with the high-level meeting for NCDs. And you can see how little goes to NCDs in terms of development assistance, and in particular, it doesn't go to the poorest countries because it's really a middle-income paradigm. And so we've been building on the 16 countries that work to have their own national commissions, and we were enlarging that in an NCDI poverty network, and particularly building a structure to initiate Penn Plus services through a 4-phase process leading to national scale-up. And we had an additional 7 countries join this network that we launched in December of this last year. You can see where they're located. And we've been working actively with the World Health Organization to scale Penn Plus through a Penn Plus partnership as one of the key initiatives of this project. So thank you for letting me talk a lot here, and I hope there's just a few minutes here I know left for discussion, and I'll hand it back over to Oyeri.
Jean, thank you so much, for that talk. I think that this work is extremely important, that you're doing, and, it's wonderful to see the expansion of the work from what you've done in Rwanda with the Lancet Commission, and really kind of seeing, the work going on in different countries. I'm going to open it up for questions, so perhaps I'll take, the liberty of, sort of asking the first one, or sort of making the first comment, which is that, as you know, and as we've discussed many times, the issue here is one of a significant amount of complexity, where we, try to shoehorn this low and middle income countries into kind of this shoebox, where in reality, especially for NCDs and for cardiovascular diseases, that, low and middle distinction is very critical. They're not the same and they're not doing the same things. As well, sort of, the rural urban distinction, which you kind of hinted at, even within a low income country, that rural urban divide, creates sort of, almost two different ecosystems as to what's going on in terms of cardiovascular disease. So I think that, that complexity has been tough, to get a, very neat looking paradigm to fit around, but also means that, the conversation we should be having is not the, or should we do this or that, but the and, how do we do these things, together in a way that, makes sense. So I just, wanted, it's more of a comment than a question, but, wanted to highlight that that's, one of the real complexities of dealing with this. I have a question here from Dr. Erica Spatz, sort of saying, can you speak to the idea of leveraging infrastructure for HIV prevention for cardiovascular diseases?
Yeah, well, Yuri, thank you, and I think you're absolutely right. It's definitely an and we're in this case we felt like there was a gap that was really falling between the cracks of what was being done, and so we're trying to focus on addressing that gap. But as you say, there's lots of gaps, and they're in urban areas that there may be a greater need for addressing some of these risk factors that are becoming more prevalent. I mean, these risk factors should be addressed everywhere, in a sense, even if they're at a very low prevalence at this point. Erica, it's interesting. I tend to be a little bit contrarian on the leveraging HIV infrastructure question. There's an issue, there's an equity issue with the HIV one, which is, if you look at this is sort of a hard thing to say, but I think that there is some truth that if you look at patients with HIV who have these cardiovascular risk factors, they tends to be more urban. It tends to be less poor than the rest of the population, tends to be older. And so if you have an idea, and I say this because this is actually where a lot of the action is on non-communicable disease globally. If the idea is that, okay, well, we'll address this aspect of non-communicable diseases, if you think about it, it's really very inequitable, because you're leaving all the children, all the younger populations that largely don't have these comorbidities. Granted, I mean, for sure, folks should have their risk factors, managed if they have HIV. It's an important thing to do, but it's often, again, kind of presented as like, this is like a major thing for NCDs in general, which is, as we've shown, it doesn't really, most of the stuff that we're talking about has nothing to do with, there's very little comorbidity between rheumatic heart disease and HIV, or at this stage, most of the cardiomyopathies and HIV, or most of these other diseases. So I think it's an important thing to do, but there's that caveat. The question about training NCD specialists, thank you, Professor Velasquez. So I'd say there's two things. One is that I think that cardiologists are, as an example, are incredibly important to this work, and there's hardly any of them in Africa, say. Or not enough of them, and I think that's building the cardiology workforce is going to be critical for the success of this. But with that, there's a need for cardiologists to have a public health orientation and to see their role as managing larger health systems and working with middle-level providers across the country, which is not typically our orientation and our training. And that's sort of the second point, is that we've sort of provided an example of how you can train nurses, mid-levels, to perform a lot of these things, simplified echocardiography, heart failure management, insulin management, but they need the input and the supervision from specialists, and using things like telecardiology, video conferencing, et cetera. So I think it needs to be kind of a both and approach, and I think that there's also a big role for cardiologists in the U.S., et cetera, to be involved in these kinds of training initiatives, where to support the initial groups of nurses in these places to be able to do things, particularly like echocardiography, even a couple weeks from an echocardiographer, can be very valuable. So I think that there's a lot of room here for partnerships with American and European cardiology societies.
Excellent. Jean, again, we're at the top of the hour. Thank you very much for spending this hour with us, and really kind of this wonderful work that's very thought-provoking. I think we'll all be thinking for quite a while of the paradigm that you've laid, and really kind of our role in it. So thanks again, and hopefully we'll see you in person sometime soon. All right, thank you, everyone.